everyone. Welcome to the 27th TCTAP. We have today a live case session on complex PCI from the Asan Medical Center, Korea. I'm here with my co-moderator. My name is Dr. Ashok Seth, and I'm here with my co-moderator, Yves Louvard from France. We have a tremendous panel with Dr. Nakamura, Aniket Puri, Imad Shiban, and Chingzhen Wu. And I'm sure we're going to have good discussion and good interaction for your benefit. The cases at the Asan Medical Center are going to be done by Professor Park, Dakwu Park, and then a second case also by Jungmin An and Dr. Park. With these words, we start off with a live case from Asan Medical Center, Korea. Over to you, Asan Medical Center.
Okay. Hello, everyone, and all of you. I'm very pleased to see you, our long-standing friend. Welcome to TCTAP 2022 live case demonstration. So, in this session, we prepared a very complex coronary intervention case. My name is D.W. Park from Asan Medical Center. I'm going to introduce my team and the senior fellow and Dr. Jinho Lee and our senior technician, Kang-Soo Jung. Okay, Dr. Lee, can you introduce patient background?
Yeah. Okay. I'm Jinho Lee from Asan Medical Center. Let me show the brief summary of this case. 47 years old male patient was referred for effort chest pain. He was performed coronary angiography in other hospital, and the results showed the distal left main bifurcation disease. So we planned the revascularization of this lesion. So he has no past medical history about coronary artery disease. Next. And he has an underlying disease which is hypertension and hyperlipidemia. And so he is a current smoker with 30 years of smoking history. The clinical presentation of this patient was stable angina, CCS class 2. And next, the electrocardiogram showed the basically normal sinus rhythm without ST change. Next, this chest radiograph, there is no evidence of cardiomegaly or pulmonary edema. Next, the non-invasive study showed the echocardiography showed the normal range of LV ejection fraction. So let's show the coronary angiography performed in outside hospital. Next. First, this is right coronary angiogram, and mid portion of LCA have a severe stenosis, approximately 70% of luminal narrowing. Next. And this is left coronary angiogram, and this caudal view show the distal left main disease and ostium of left circumflex artery. And caudal view, cranial view of diffuse stenosis of the mid portion to proximal LAD. And sepidal view, we can see the very tight lesion of distal left main and bifurcated disease include proximal left LAD and proximal left circumflex artery.
Okay, so I'm gonna briefly describe that this patient is a 47. A relatively young patient, male, presented upper chest pain 3 months ago, and he has hypertension, hyperlipidemia, and smoking, and the 3 risk factor. And another hospital that directly checked the coronary angio, there was a very tough region. So today, we checked the coronary angio, the RCA, mid RCA part, there is some significant stenosis. And next one. This is AP cranial view. We can see the mid part, and there is some 60 or 70% significant stenosis. And next one. Today, the live case, the target lesion is a distal left main, as you can see, and there is a distal left main is a very tight lesion. And even though this patient, the 47, relatively young patient, the sock ostium looks tight, distal left main also looks tight. by definition, it seems like 1-1-1 Medina crescent. Next one. This is the two zoom RAO coral view. We can see the distal left main and the severe stenosis. Also, sarcoosteum is looks like the severe stenotic. And the next one. This is the RAO cranial view. And next one. This is AP cranial view. We can see the medial LAD lesion was extended medial LAD part. And the distal left main looks very tight. The next one. This is aerial cranial view. We can recognize well how much severe the distal left main tight lesion. And next one. This is the spiral view. You can see there is a very tight lesion of distal left main and the sarcoosteum also involved in the LAD osteum. And that this is definitely 3 vessel disease, distal left main bifurcation lesion. Syntax score is 32 and the relatively young patient, the 47. So I would you like hear some comment or question for this patient decision making?
So I think it's a great time for discussion. And can I then ask Yves, my co-moderator, who's been a part of a lot of bifurcation guidelines in Europe. Yves, what are your thoughts when you see something like this?
This is a complex case. Of course, this is a lesion that has been to be performed by an experienced operator. This is you may have heard that we have published the EBC main result last year, and I have to see that this is typically the kind of case we perform in EBC main, which was randomized to either a decision of systematic double stenting, whatever the technique, was in majority of culotte and destenting on tap, versus provisional procedure trying to put only a single stent. So you may think this is difficult to say that, but this is exactly the kind of left main that we have randomized. So in my place and in majority of cases in Europe, we'll probably receive a provisional strategy. I mean, preparation of at least one of the 2 vessels. I don't see severe calcification, so I presume will be relatively easy. After that, stenting either toward the crossover stenting either towards the third or toward the lady. I think in another projection that this one that LAD is probably tighter than the circumflex. So probably the first stent will be deployed from left main to LAD, and we spot all the traditional steps of the provisional strategy.
Thank you, Yves. So that's a provisional strategy, and I think I would say there's mild calcification because you can just about, it's not tram track, but mild to moderate. You can see some calcification even on the angiogram from here. Well, Professor Nakamura, I mean, I would have thought that I would make these decisions more on an intravascular ultrasound. Would you be making these decisions of provisional versus 2 stent based on ultrasound IVUS, or are you quite okay with a provisional strategy for this? And if it was provisional, is your provisional left main to LAD or provisional left main to circumflex?
First of all, need to check the IVUS to see the evaluation or the clarification, and also to check the presence of the plaque in the circumflex ostium. And maybe I think they need to decide a strategy, I think. But this is very actually interesting case because this is big circumflex. Usually circumflex size is not so big, but this is big circumflex. So should be care both LAD and circumflex. This is very interesting. But first of all, need to check the IVUS.
So in the interest of time, we would proceed unless Professor Shaban and Aniket had a short comment to make. And I do believe that the circumflex is more diseased than just the ostium. And I think it's important when we look at that large OM, it's important to look at the calcification, important to look at the proximal circumflex, and I'm sort of more gearing towards a 2-stent strategy based on intravascular imaging. So Professor Shaban and Aniket, yourself.
Yes, sir. I think you're absolutely right. I mean, looking at the angiogram, certainly a two-stent strategy comes straight to mind. With an image guidance, either an IVUS or an OCT. That's what I would do. This kind of a case over here would be discussed in a heart team and then brought back for a elective left main two-stent strategy. That's my understanding.
Imad, any addition to what's been said?
Yes, I think the first step here is to take intravascular imaging to define well the lesion, extension of disease. It seems to me that the extension of disease on proximal circ is quite significant, the whole proximal segment. And I think also LAD should be IVUS in order to see how much the ostium is involved. Then accordingly to strategy choose, that means 2 or 1 or single stenting, I think you can decide whether to cross and accordingly to intravascular imaging results, whether to cross from left main to circ or left main to LAD. If it is a 2 stents technique, I think this is not a big problem. It's not any more problem. In case you will take, you go for provisional stenting, then I think you should be based on intravascular analysis.
Absolutely. I absolutely agree the Dr. Imad Shivan's comment, and we already checked the IVUS. Could you show us the IVUS? So we are already checked the Boston intravascular ultrasound. This is the LAD and the mid LAD part, and we can see on the basis of IVUS, and we decide the vessel size. This is a nearly subtotal region and the 3.0 vessel, and this is a mid LAD. As you can see the angiogram, and this is the mid LAD very tight portion, and the more the faster. Pull back more faster. This is a mid LAD part. Okay, this is the prox LAD, and then more faster, and we will show the LAD ostium. Okay, this is just the prox LAD. Vessel size is much bigger than mid LAD part, nearly 4.0, and the plaque was there is an eccentric plaque, and the LAD ostium seems like a 4.0 vessel. Okay, more faster. Okay, this is a 4.0 vessel, 4.0, and the more faster. Okay, over here we're gonna show the LAD ostium. Soc ostium is coming the 1 o'clock. We can see that this is how much tight this left main region is a nearly subtotal region. It's 95% the diameter stenosis, the lumen area less than 1.5. Left main vessel size is absolutely 4.5, and the plaque was extended left main. Also, we're gonna show the proximal soc region. So, and here is the proximal soc. Okay, the prox soc region is a 3.5 vessel. 이거 바꿔주실래요? Okay. 자, 아래 coral view. Okay, show. This is 3.5, and the soc region, and the plaque was. I think this. If you're gonna decide a two-stent strategy, this is we decide 3.5. Okay, here this is prox soc, and this is the soc ostium. It looks like a very tight over here. Not yet the exact soc ostium. Okay, over here, this is soc ostium. It's nearly very severely narrowed part, and the soc ostium also prox soc. We can define these 2 very tight regions. So we are, after recognizing the intravascular ultrasound, also, and although we know the EBC main result and the TK Crush 5 trial, although some conflicting data, and the soc is a very big size soc, also LAD and left main severe disease, and we are finally choose the upfront 2-stent strategy, and our preferred choice was a crush technique. I'm gonna do, and we are finally decide course technique. Any comment after checking the intravascular ultrasound?
Yeah, apart from the comment that I had was, yes, your approach is correct. We saw calcium also, well, it was only 90 degrees as we went into the LAD, but the distal circ had a circumferential 270-degree calcification, but it didn't seem too, it was in a short segment of a length. And I think I was just thinking that whether you would use a, would you use a cutting balloon or an additional adjunctive scoring balloon or something to get your best advantages at the ostias of the posterior.
Okay, next one. We already do pre-dilation using NC balloon. Next one, we use the 3.0 NC balloon to crack down. Here is a 3.0. Next one, NC balloon, non-compliant balloon 3.0. Next one, and next one, and next one. And then we move to the sarcoostium. This is a NC balloon 3.0 expanded well. Next one. And this is 3.0 next one, right? And then the 3.0 next one, and we check the after pre-dilation. Is a calcium is much cracked, lumen was much improved than before. So we are finally decided to the crush technique, and on the basis of IVUS finding, LAD requiring two long stenting, the mid part LAD 3.0. Okay, here. Okay. 뒤에만 맞추면 되죠. 테스트. 여기네, 그죠? 테스트. Here. 자, 3.0 and the giant stand. 12. Okay.
Again, I think for the audience, one wants to emphasize that
this
was the right way to do it, put two stents, because of the discrepancy between the distal LAD and the proximal LAD and the left main. And therefore, if you want to get to the best results, then these would be two stents into the LAD so as to be able to match the anatomy.
Yeah, absolutely. I think I fully agree the Dr. Esho says the comment, and if you're gonna treat the very long region, especially middle LAD and the prox LAD, left main, there would be some size discrepancy. And although today we use the giant stent and the next version and the synergy at Megatron, and this is a much is a higher radial pulse. A new version of the stent would be much valuable to treat this like very big size stent. Okay, this is 4.0 NC balloon to put the LAD part, and then I'm gonna decide the 3.5 giant stent to treat the sarcoostium. So, and still, I think arguably this is like a true bifurcation region is a big size circ, and although the EBC main the proposed the provisional was a default strategy, I think initially in the provisional stenting strategy is such like some true bifurcation region sometimes not feasible. So at this moment we are decided to upfront to two-stent technique.
So Professor Zhenwu, what are your, do you use cutting balloons on these ostias? I saw some
I probably
on the LAD balloon.
I catch your question because I see that IVUS imaging a 360-degree calcium somewhat deep in the left main distal portion. So I wonder if we can do a imaging study before we do a crush, because if a lesion modification is not that good, maybe we need to do further maybe 3, 5, 4 to kind of crack that the calcium before we do the stenting directory here.
And the way I see it is that it doesn't, the LAD ostia seems to be resilient and resistant, and I saw that indentation in that 3mm balloon.
Yep.
Okay, this is a 3.5.
Okay, if you use a shock wave, that will give you a much better result for pre-dilatation and break the calcium down. So we've got a lot of shock wave now, and that provides good pre-dilatation, especially if there's 270 plus calcium, then, you know, if you can get some cracks through and then push it out with an NC balloon, I find that putting the stent is a very easy job from there on.
Well, that so Dr. Puri had said about IVL for the osteas, which is certainly a very good strategy.
3.5. Yeah. So we do stent balloon high pressure, and then over here, people removing the wire, and I'm gonna do additional NC balloon dilation for make sure much easier to side branch wire approach. Also make sure more, you know, the nice the stent expansion. Okay, this is 3.5.
So Dr. Park, while you're doing it, a bit of technique also for the audience. How much did you protrude out into the left vein? Was this like a micro crush? Was it a mini crush? Or was
previous
it
one.
Was
So
it,
yeah, that is a very important previous one. 딱 거기 맞출 때. So there, I think that is okay. Previous one. Okay, next one. Okay, I think that is a very important question. Usually, and the left main, the stand was the position, and I tried to do some touch of the proximal segment and slightly 1/2 millimeter, and then the impression. Usually, you know, rather than classic cross technique, I would like to do just a mini cross technique.
Yeah, and we see that very nicely. You just got the ostia. You're a millimeter before the ostia. And I think that's like a mini crush, which is very nicely demonstrated.
Absolutely.
Yeah, absolutely.
Have a comment?
3.5. This is a 3.5 NC balloon. So I think previously we just do, you know, recorder to stent the high pressure balloon and then remove the wire. So nowadays we recently updated our technique. At this moment, we apply to the NC balloon. Okay, stent boost over here. 자, go 6, 8, 10, 12, 14. This is 3.5, same size NC balloon. 자, deplete. This is much easier. Recross the stand. Okay, go. 6, 8, 10, 20.
20.
Okay, deplete. Here is we apply the NC balloon, and then we're gonna remove this one and the side. This one. This is a sock wire, and then remove the sock wire and stand. Slightly pull back over here. sock wire 이거 맞지?
네.
나오고 있죠? Okay. Fully remove.
I think the mini crush is a very interesting technique. This is what we observed in any technique. Mini culotte, mini tap. I think this stent now is at the ostium of the sock, and what will occur with this balloon is partly an axial crushing of the stent in the side branch.
Yeah.
So it will limit. We see it. We see it.
Okay, I'm gonna.
It will limit the thickness and the length of the neocarina, which is interesting.
Okay, go. 6, 8, 10. This is a 4.0 NC balloon. Okay, deplete. Okay, before put the main branch, the stand, we are to crush the first using the NC balloon. So, and compared to previous our technique, we now apply some new additional technique. The before removing the sock wire, we're gonna do NC balloon based high pressure dilation 2 or 3 times, and then finally remove, and then put the LED stand, and then that is much make it easier to side branch recross.
Yes, you
question. I think it is important to underline that crushing the stent should be with 1-to-1 balloon measured to left main. That means 4/0 in this case at least.
Okay,
yes.
This is stent booster. 자, epicranial. We would like to cover the whole segment of left main.
So just to emphasize on Dr. Park's comments around why he did that high pressure at the ostia, is to make sure that the stent is opposed to the ostia so that when you
Okay,
cross the
test.
second wire, you don't go
이거
behind the
나쁘잖아.
stent
그러면 이제 그걸 봐야 돼.
at the ostia, where when you crush, you can actually remove the stent away from the wall.
Okay, good. So we make sure overlap. Okay, test.
Ashok, this is another essential point.
Okay, go.
I agree with you.
하겠습니다.
Yeah.
12 하겠습니다.
12.
12.
Okay, 12. Okay, save. Deplete.
But I like the expansion of the balloon at this time, that the LAD balloon at the ostia is expanding fairly well. And I think that's an important aspect to keep in mind. Those are the resilient
NC balloon
areas.
again. 4.0.
So this was again a science platform that you put into the LAD left main.
Yes, this is used the giants, and I think any stent would be okay for contemporary drug loading stent. Although we published some different outcome in chip region like a bifurcation or some calcified region left main. I think the current contemporary stent is very nice. So although today we use the giant stent, we can use the Resolute or the Synergy or Ultimaster. Okay, go.
And this is to Yves, my co-moderator Yves. So again, for the benefit of the audience, I think there are 2 points that we should comment on, and perhaps the first comment would be from you.
Okay.
Do you have any choice of stents because you have to cross the balloons, so on and so forth? Do you have any choices for the side branches in terms of stent preference? And I say that because EBC Main was with the Medtronic Onyx, which is an open cell design and allows wiring and crossing into the side branches more easily.
Okay,
Any thoughts on that or comments on a preference of stents?
Difficult to say because we have not found discussion we had in the club. We have not found any difference between different stents. We have now nearly all the companies now have a specific stent for left main. Specific, I mean, the big stent for the big expansion. I think this is most important before beginning the procedure to be sure that you will have a stent that not only accommodates the distal vein vessel but also the proximal vein vessel. So this is the most important.
Right.
And
so that's the most important.
Also the advantage of these big stents is that the cells are bigger and we can exchange the wires and introduce the stent to the side branch much easily now.
So,
I think an important point.
You crossed the wire, but you should tell us more about where you cross the wire.
Yeah, so usually I think the intervention is to prepare the proximal Shaolin chain is absolutely cross the proximal part, and some physician prefer distal part. I think that anyone it doesn't matter, and usually if you're gonna do the after stenting and the pool dilation using NC balloon in the sucker part, and the wire passage is very easy. Even though previously we used some small balloon to cross the sucker part, and after this additional step, we can cross well. Even using the first use the NC balloon. Okay, LAD. That's 4.0.
Again, I think it is very important to be sure that you have expanded fully the stent
Absolutely, there is
on the ostium.
Yeah, absolutely. That is very most important part. This is 4.0.
So, Dr. Nakamura, I think again your thoughts around wiring in a crush. What is your habit? What's your practice?
Okay. First of all, we have so in Japan we have a mini study about how to select appropriate the hole of the stent. But actually, if you look at the data, if we select any point, I mean, result is not so different. So I think Dr. Park is right.
우리가 3.0 NC가 얼마
So the one
Okay,
thing which I wanted to
NC.
emphasize to again the audience is the reason for
3.5
crossing.
한번
If you
3.5
cross
나오고
too
있나?
proximally, you
한번 유지된 거
create a
나왔어?
greater carina, metallic carina, because you're pushing
3점 한번 썼나
everything.
우리가?
Most of the metal
3.5.
remains
네네.
towards the carina. You go mid, you redistribute the carina metal towards proximal and towards the carina. You go more distal, then you have more metal towards the proximal edge rather than distal edge. So my habit is to try to go as central as possible so that the metal gets redistributed. And that stands to reason that there's more carina if you just go too proximally. If the crossing is too proximally, the carina is more metallic.
Okay, this is nearly final step to the cross socket. This is use the NC balloon to try to the cross socket ostium.
So that's going to be a good demonstration. And I think if you can't, then do show everyone the anchoring technique.
Yes.
The balloon anchoring technique.
Okay.
There he's doing the balloon anchoring technique.
Okay, deflate. I think some use the balloon and sometimes difficult.
Yes.
여기서 자 한번 LA 있고 6. It was no. We should use the new one. 안 되겠다. Deflate new one. Yeah, 3.5. This is the used one. I'm gonna use the 3.5 new one and it's balloon.
What
So that
size
was the
balloon is that? What
Yeah,
size?
LED is a
another.
4.0, and we did the high pressure balloon, and the socket we tried to the 3.5. Okay, got it.
I think it's more difficult
this
to
is-
cross the used balloons through a Zeiss
Yeah.
platform than other
Yeah.
open cell platforms. We just got to keep that in mind. But now you'll be able to cross through this. And and that was, by the way, a good demonstration of the anchor technique that one can use to actually ensure crossing
Absolutely.
of the side branch
Okay,
through the
this
struts of the.
is a use the new one.
Was quite
Anchoring
courageous to attempt that, sir, in the first place.
6.
I doubt the used 3.5 would cross it.
Okay, got it.
Yeah,
Different.
there you go. Now,
Okay, 잡고 한번 올려봐. socket.
서클 가겠습니다.
6.
6,
Okay, go. 6, 8, 10.
10,
Okay, deflate.
position.
Okay, this is 3.5. 자, 이렇게 놓고 좀 더 밀어놓게. 자, 여기 한번 섞고
서클 가겠습니다.
6, 8,
8,
10.
10,
Okay, deflate.
position.
자, LED 됐다. 이렇게 놓고 자, 섞고 6, 8, 10,
서클 10,
12,
12,
14.
14,
Okay, deflate.
position.
자, LED고 10. Okay. Okay, deflate. And then we're gonna do 8, 8. 자, go. 8,
So
8.
that's 3.5 and 4. Is that correct?
Yeah, right. Okay, deflate.
둘, 셋.
One
This
more.
was at 10 atmospheres, 12 atmospheres.
8,
it's
8. 8, 8. The sock가 이건가?
예, 맞습니다.
Okay, one more. 자, go. 8, 8.
둘, 셋. 8,
Okay, deflate. 하나, 둘, 셋. Okay, I think we did all. Okay, got it. Over here. So I think we're gonna check over here, Andrew, and we remain the final step IVUS, and then would you like recommend move to second wonderful case SJ and standby?
Absolutely. So now the
Andrew.
EBC and EVES would recommend
Okay.
that we do a pot
Okay.
as
Yes.
EBC emphasizes. So EVES.
Yes,
your
I
comment.
think even 2010 is recommending a pot at the end of the DK crush procedure,
Okay. 잠깐만.
Yeah. That's
and
right.
it has to be performed a bit,
꺾여 있는 서클.
not with the distal marker in front of the carina. This will be a mistake.
찍어보자.
It has to be performed proximal to the takeoff of the side branch.
자,
If you do that,
good.
you are not modifying the position
Okay.
of the carina.
So
I
I
think it's
think
very important to do the last part more proximal than the previous one.
spider view looks good. So I would like to recommend the move to the room number 1, and then
Okay,
we
just-
finally
just-
we're gonna share the final
Just one comment before we move, and that again is for the audience. that my preference to perform a kissing is to only come in to bring the proximal markers into the polygon of confluence and not any further back. That way you get the best advantages of the kissing, and then you may or may not need to do the final pot because you haven't changed the ellipticity of the proximal stent. So I think that's another important thing. Protrusion of the balloon's proximal ends only slightly into the left main, so you end up in the polygon of confluence. Preference, which is its advantages. Thank you, Dr. Park. I think that was a great demonstration. I mean, we would have loved to see the IVUS, but I'm sure it's going to be brilliant. And I'm sure if there's anything that you need to optimize, you will optimize it. And if you want to pass us on to the next room, certainly, please go ahead.
Okay, great. Thank you.
And it was very fast. It was very rapidly done and a great demonstration of technique.
Hello.
Hello, Dr. Park. We can see you. We can hear you.
Yes, I am Dr. An. So I'd like to introduce our cath lab person, Dr. Park. Behind me.
I want to just say hello to you, all, our friend here,
Hello,
Hello, success. All right,
Mark.
so Lubat, Nakamura, Puris,
Hello, nice to see you.
Shaivan, so long time no see, right?
Good to see you. Good to see
All right,
you.
great to see you all, right. All right, we prepared these very tough cases, however, it's not too much complex for me. So Dr. Han will, give us good live demonstration, and Dr. Park too. And so you want to start?
Okay. Thank you, Dr. Park. Yes, Dr. Park at the room number 2 already performed the bifurcation stenting, crochet stenting, but it doesn't take the less. It only takes 30 minutes. As you observed that we prepared another bifurcation case. But we already applied a different strategy. Dr. Park, could you explain, could you introduce the patient brief history?
Yes, I'm Jinsun Park from Assam Medical Center. I'm very glad to present this case. This patient is 70-year-old male. He was admitted for abnormalities on coronary CT scan. This CT scan showed significant stenosis at left main and proximal to medial AD. He didn't have any history of MI or revascularization before. Next. And he has a hypertension and he's an ex-smoker. Actually, we diagnosed him as a silent ischemia. Next. If you look at the baseline ECG, is no definite pathologic Q wave or no significant chest change of ST-T wave. Next. And there's no definite cardiomegaly on chest PA. Next. And we also evaluated some non-invasive studies. On echocardiography, he has normal LV systolic function without regional wall motion abnormality. But in treadmill test, there's some ST elevation in ABR at stage 4 without symptom. Next. There's a baseline coronary angiography. As you can see, right coronary angiogram shows nearly normal coronary, but in left coronary angiogram in this PA caudal view, there's angiographically significant stenosis at distal left main to proximal LAD. So
yes, today, yes, this is definitely just a left main bifurcation case. Today we check the coronary angiogram again. This is, can you see? Yes, this is just spider view. This is left main stenosis. There is actually that bifurcation, trifurcation. There is proximal edge stenosis. RI range, I'm not sure, high diagonal or high OM, I'm not sure, but there is just some stenosis, proximal portion. And circumflex ostium, the stenosis, there is some stenosis, but I'm not sure. Next. This is caudal view. So this is the left main bifurcation lesion. Some stenosis, stenosis is confined to the distal left main and proximal LAD. So do you have any comments on case?
Any FFR study for the circumflex mid portion and proximal portion, because distal left main extended to the mid portion circ. So this maybe change our strategy.
Yeah, I think that this is a very important question. We have to document any kind of objective ischemia before the PCI, any kind of PCI. In this patient, we measure the FFR, not for the circumflex, but the LAD. FFR is 0.60. But the stenosis is located in the distal left main, so circumflex FFR is not, circumflex FFR is a combination of distal left main plus the circumflex. So if we needed to further treatment, we have to measure the FFR again after the distal left main treatment. So anyway, we documented the objective ischemia for distal left main to LAD. FFR is 0.60.
I think it is. I think it is good to.
Sorry, Ahmad, go ahead. I was going to ask.
I think it is good to take intravascular imaging also in this case for CIRC. It seems on angio that the ostium of CIRC is not that much affected. So if it is like this, I'll make it as simple as positive as possible. So going for provisional stenting.
Yes, so according to the Dr. Saiban's recommendation, suggestion, we already performed the intravascular ultrasound imaging. Please show us that the LAD pullback first.
And there's one more reason, by the way, I was just going to say one more reason to make it as simple as possible is because there's a large intermedius which comes across, and we'd rather not have start with a provisional strategy to see how those two vessels behave.
Okay, please show us that LAD pullback. Run, please. This is prox LAD pullback imaging. So the vessel size is almost 4O. At least 3.5. So this is just started here. Very narrow, very large plaque burden. The vessel size is almost 4O. Looks very soft plaque, not so severe calcified. There's some superficial calcification, or almost the soft plaque. But there is some superficial calcification at the 6 o'clock, but still, prox LAD is very large 4O. Stop, please. Can you see this is the high diagonal branch by definition. So diagonal ostium image looks fine based on the LAD pullback imaging. Run, please. Stop, please. This is the circumflex wire. The circumflex coming from the 9 o'clock. Circumflex ostium looks fine based on the LAD IVUS. Go ahead. Yes, looks like, stop, please. Here is this left main. This left main, 360 degrees superficial calcification, very narrowed. Next, go, please. Left main is very large, more than 4O. Here is the shaft of left main, looks fine. Here is the proximal left main. Okay. Could you show us the high diagonal pullback imaging? This is a high diagonal pullback. Go, please, long, please. High diagonal is only 2.5, some disease. Here is a very ostium, stop, please. Here is a very ostium of high diagonal. Plaque burden is very small. In our very preliminary small analysis, to predict post-stent crossover FFR value, to predict FFR less than 0.80, there is two criteria. The first is plaque burden. Plaque burden is more than 50%. Minimal lumen is less than 4. But the plaque burden is very small. So for the high diagonal branch, go, please. And could you show us the circumflex ostial pullback imaging? This is a circumflex pullback imaging. Special size is 3O. Stop, please. Here is a very ostium of a circumflex. So the angiographically intermediate stenosis, I will show the very ostium of a circumflex, the very ostium of a high diagonal branch. Lumen looks fine. So based on this IVUS findings, we decided to perform the simple crossover stenting. Do you agree?
Yes, we
Absolutely,
agree. We agree. And Yves, your comments. I mean, this is again something that you would have. Would you have randomized this in EBC left main? Was this one of your randomized cases?
Yes, certainly.
And trifurcation. Was trifurcation a part of the randomization?
It's a trifurcation. Yeah, there was some trifurcation in the EBC main.
Right.
And I would do what was described because of the static preparation because of calcium is maybe lithotripsy, why not? And after that, three wires, long stent to cover the proximal LAD towards the left main pot, kiss pot, and after that wire exchange for kiss, and look at the result mainly on the intermediate, which is a major vessel, maybe as important as the circumflex web. So three wires, of course.
One more observation, may I just suggest, and then I'll pass it on. For angiographically, the ostium also seems to have a plaque. Was that noticed on the left main? Because that means that whether we have to come up to the ostia rather than the body of the left main. And I think that's an important observation we should have a relook at. Because angiographically, certainly, there's a plaque in the ostium of the left main.
The other aspect is that you have 360 grade calcification on distal left main. So I wonder which kind of debulking you are using now for the preparation.
Lesion preparation.
Okay, for the lesion, I think lesion preparation is the most important thing to achieve the sufficient stent area. So we prefer the high pressure ballooning. So this is a 3.5 high pressure balloon. Test, please. Okay. Here is the proximal lesion, 10.
10.
Okay, proximal LAD, there is no severe calcification. Expansion is very nice. Deflation. I already removed the circumflex wire. 3 wire is very complex. Circumflex ostium looks fine, but the high diagonal branch ostium is a little bit smaller. So I keep the high diagonal branch wire and I remove the circumflex wire. 10. Here is this left main.
10.
12.
12.
Can you see some indentation? 20.
Yes, we do. That's right.
20.
Higher pressure.
24.
28.
28.
Okay, 28. Deflation.
What about can do IVUS before we put a stenting? Because I like to see a cracking of the 360 degree of calcium.
Okay.
Is that okay?
Okay.
A good comment, Zhenwu. And again, for the audience, it's been clearly demonstrated that certainly for balloon angioplasty followed by stent implantation, in that subgroup of patients, and Professor Nakamura will tell us more about that, great data to suggest that if you don't see cracks and fractures, you have inadequate stent expansion, greater chances of inadequate stent expansion.
Yeah.
Just checking, Dr. Anand, do you have shockwave in Korea?
No, unfortunately, we don't have a shock wave.
What about scoring and cutting balloons?
But I don't think scoring cutting balloon is more effective than the high pressure ballooning.
High pressure,
me too. I think high pressure is more effective than scoring or cutting balloon. So according to your suggestion, I'd like to see the breakage of this left main severe calcification.
Yeah.
After there is just some breaks of calcification. So I like to implant.
So let me just ask you this again for the audience: you don't have IVL, and now you've really dissected the vessel quite extensively. And if you don't see fractures and cracks, what would you do?
Still.
Okay. Yeah.
There's a couple of cracks there.
Yes.
Can you be there? You fracture the calcification.
Again, run again, please. Some dissection and circumflex from the seminal cleft. Stop, please. A little bit, 조금 뒤로. Okay, here you can see the some breakage, at least the 4
12 o'clock,
cracks, 12 o'clock,
Yeah.
3
3
o'clock.
o'clock,
and
9
So
o'clock,
the
7 o'clock.
yes,
7 o'clock.
I
okay,
think it's straight-
2 or
straight
3
up
breakage.
this
Maybe
kind of
OCT
approach is
in this
straight up
case
the alley of
will
a
give you
shockwave,
more
because you get
detail.
lots of cracks with the even at a lower pressure with the shock wave. And then when you pre-dilate, you get a really good movement of the calcium away.
Plates.
Yeah, I think this
It's
is a very
interesting to
good.
see how the stent goes, because I'm still not 100% certain.
Mm.
You've got
Okay,
great, preparation of the lesion.
okay.
So what's the thought behind the orbital atherectomy?
Yes. Orbital
we are-
atherectomy would be a good option, but unfortunately, it is not available in Korea. The only one, the working device available in Korea is rotablation. But the lumen area in this case is very more than 2 old. So I think rotablator may not be effective. So
At this stage, rotablate, the only options we would have is if they had IVL to take it further, or ultra high pressure balloon of the same size to take it higher. But I think we just got to work forwards, given
So I
the
think
limitations
even a
of
cutting balloon
technology.
at this stage, I agree. If it's still not optimal, if the cutting balloon is available, good old cutting balloon, which has been around for quite a few years, it might give us some additional advantage.
And by the way, Aniket, that's also been seen for rotational atherectomy, followed by cutting balloons, give larger lumens than just rotational atherectomy and balloon balloons.
Too short.
So yes,
It's a little bit too short.
Tester.
I think your comments are well valid.
Okay, 갑시다. Okay.
Well, that's good.
14.
14.
Deflation.
Deflation.
What is the size of the balloon?
This is 3.5, 30 Resolute stent.
That's
18.
expanded nicely. Even just those couple of cracks worked.
Yes. 18.
18.
Left main is lumen is 4O, so I can inflate 18 atmosphere using stem balloon deflation.
Yes, but now you will have to put the second stent at the ostium of the left main because it was dilated.
Yeah, there's a disease there. Yeah.
There is no disease.
Yeah, but it was dilated. So we remember
10
years ago we had many. That was why we recommended to go to the osteum, because we were observing many osteal restenosis after incomplete stenting of the left main. So this is related to balloon. This is
yeah, that is the point. I think you should go for both a short balloon and stay inside the stent. Otherwise, otherwise patient will be coming back with restenosis, of course. Yeah.
That's right.
Yeah, that will be good. Yes, that is a very good comment. Just usually, if there is just some disease in the left main, yes, I'm very careful for the high pressure balloon. So the high pressure balloon should be located inside of a stent to avoid the vessel damage. But in this case, left main lumen is very big, the more than at least 4.3.
That's true.
And there is a very minimal disease, so I don't care the left main, the pull-up regrowth, something like that.
Just for the benefit again of the audience, and there might be a lot of learners out there, Dr. Ahn knew the size by IVUS, and therefore he went ahead and pulled the balloon back and inflated it into the left main at high pressures. But that's the sort of strategy one would normally do if you've covered the ostium with a stent, and then you can certainly bring the balloon back, go to any pressures as long as the whole of the left main is covered with a stent. Otherwise, you do have concerns around just pulling the balloon back into uncovered left mains.
Yeah, I agree. So this is for high pressure balloon, 14. Approximately the vessel size 4O. So during the IVUS guided PCI, the operator should have a deflation, should have idea of all anatomy of this left main and proximal AD and circumflex.
By the way, and I again want to emphasize, you saw both these cases being done with imaging guidance,
Yeah.
10,
which
14,
is so important in
16,
terms of
18,
strategies and in terms of making sure that you not
Correlation.
just have an optimal result, but a safe result as well. These high pressure
18,
dilatation,
20.
going up in calcified lesions to extremely high
20.
pressures of 28 atmospheres is only safe
Inflammation.
because you know the sizes of those vessels.
Ready? I think it looks fine. I'd like to check the IVUS.
May I have a comment?
Yes.
Please do.
What
Yes,
you have done is a successive inflation of a big balloon from LED to left main. So we have not done the pot. So you don't have any more two diameters between left main and LED now. So you need a pot to reconstruct the anatomy of the bifurcation.
Okay.
And Yves, please, because there's a lot of audience who would like to understand what you said. I think for the audience, can you just say a bit about how to do this spot and why do you want to do this spot in the left main?
Because what I've seen, if you went with a 4 millimeter balloon from mid LED to proximal part of the stent in the left main, you have only a single diameter. But a bifurcation has 3 diameters. This is important for flow. So I think it's important to have in the left main a different and bigger diameters than in LED. Try to, I know this is recommended in Korea because you have the famous rule of 9, 8, 7, and 6, or 8, 7, 6, and 5. So this is not really fractal law, but this is telling the operator that he has to reconstruct the 3 diameters of the bifurcation.
Yes, I think we have a little bit different strategy because part is very important when you do the angio-guided PCI, I think. But if you do the IVUS guided PCI, we already knew the vascular diameter, plug location, etc., etc. So in addition, final IVUS shows that how to optimize the stent result. Please show us the final.
Yes, what I understand with the discussion is that you are privileging bigger is better on the respect of over the respect of the anatomy.
Yeah.
So this is interesting because this can be an interesting discussion, and why not an interesting trial?
Yeah, this is a landing area. The plug is very small. Stent lands on the very minimal plug area. Stent expansion is very nice. I implanted 3.5 stent, 3.5, 30 millimeter stent. Expansion is so far so good. So from here, I already applied the 4O high pressure balloon. So here is basically the soft plug. So stent expansion doesn't matter. But my focus is here. Yes, this is a left main. Here is this, maybe this is a left main, but the lumen size is size-wise is very big. So here is a shaft of left main. Expansion is so far so good. Okay, look at the no damage, no dissection at the inside of the plug. So left main lumen is 4O, more than 4O. So we can safely apply the 4O high pressure balloon in this case. Could you measure the minimal, this the left main calcified lesion? Maybe here, yes.
Yeah, and that's the distal left main.
Yeah,
that's right.
That the calcified point, I think major calcification is there and still somehow underexpanded maybe.
Yeah.
I'll go for high pressure or a bit bigger balloon.
I like to apply the 4 high pressure balloon again.
Correct.
But already we achieved the 9.0 sufficient minimal stent cross-sectional area. I believe the bigger the better. So I applied one more high pressure balloon.
Actually, now there are some very short pot balloons available on the market with high pressure balloons. And I think in 6 millimeter balloon can be doing the job here and to do real pot without protruding in LAD.
Right. And he doesn't mean 6 millimeter diameter. He means 6 millimeters length.
No, length.
Yes. That's just a clarification.
We are not in carotid. No.
14,
14, 16,
16,
18,
18,
20,
20,
24.
24.
But this is again where I would have used again a shorter balloon.
Can you see the full expansion of a balloon? 24 atmosphere, 4.0 high pressure balloon. Use the one.
Okay. So after this, we can check IVUS to see the gain after high pressure.
Yeah, that's a good idea.
And we must not forget that we still need to see the ostia of that large intermedius, which was more diseased than others. And the more, and that's one of the important aspects of Yves was saying. I would have done a pot also for the reason that I could perhaps open up the cells more towards the intermedius than continue to shift the plaque into the intermedius by crossing it all the time with high pressure balloons or inflating high pressure balloons across it.
Ready?
I agree with this.
Okay.
Yeah, you see.
But the circumflex and high diagonal branches still survive. What is good? So compared to the LAD circumflex, the high diagonal sublunar myocardium is not so good. That's so big. So I prefer the medical treatment in this case. Team 3 and list.
Tom's doing it beautifully. I must say that these are great experts. Asan Medical Center is a center where the largest and the earliest data of left main bifurcations came from. And a lot we learned from Asan Medical Center. The whole world's learned from it. Just a point for the audience, and many of them are trainees and young fellows, is that when you do left mains, make sure that enough stent is protruding into the left main so that you can actually do the pots with 8 millimeters and now 6 millimeter long balloons. And I think that gets to be an important aspect. That otherwise, your pots do not become efficient enough.
Yeah, I fully agree with your comments. Thank you. So, okay. Okay, long, please. Yeah.
Yeah, now.
Okay. Here is a calcified lesion. Yeah, here. Bigger
Now
than before.
seems to be better.
Yeah.
Certainly improved quite a bit.
I think you should consider also some deformation of IVUS imaging because it is curved. There is a bend in this left main. So I think we should take in consideration also this this aspect. I mean, some deformation of the imaging, not symmetry, no symmetry of the imaging.
Ready? So, sorry. Ready? Very big. This left main proximity.
Absolutely good.
A French.
Yeah.
A French guidance.
So this is a French guiding catheter. So this is our final angiogram. Do you have any comments or?
Can you do a slightly more LAO just to have the trifurcation inside the trachea? See, like this, yeah. We see better the takeoff.
Seems fine.
Yeah.
So can we discuss regarding the transradial 7 French also can do such a good job? So compare with the femoral approach, A French, what do you guys prefer to do that left main bifurcation like this?
I fully agree with your comments. If I have a confidence that this case definitely will be a simple crossover case, not 7 French, 6 French is enough. But it looks complex. The treatment strategy can be changed during procedure. Sometimes we need 2 stenting, etc. So in such cases like this, calcified lesion, we may have some complication during the procedure. Still, we prefer the A-French femoral approach. So yeah, femoral complication.
How about the PD3 OCAT? You know, the OCAT has a nice internal diameter, and it can. That's what we use for radial approaches. So 6.5 or 7.5 OCAT gives us a good, almost the same capacity as the 8 French, but very nicely done.
Yeah. Radial approach is a very good option to avoid the bleeding complication for excess site. But sometimes the backup is not good. So sometimes we need a large bore. So we still prefer the femoral approach.
Yeah, I agree. In some cases need to go for femoral. Yeah.
So, we have a short time for discussion and then closing. We have now 5 minutes. What do you think about that intermediate? Does anybody have any concerns?
I have. I think what I will do, not to try to. I will certainly try to open the osteum of the intermediate. The circ Bonkonku has showed us that many times the tight lesions we see are not really tight with FFR. But I have a concern with this long lesion in the intermediate. This is what Bonkonku will call a relevant side branch. I mean, able to create event by itself, ischemia, and have to go on with medical treatment. So certainly I will open the osteum of the intermediate.
So Yves has got a very relevant comment. Professor Ahn, I'm going to ask you this. Would you actually do an FFR on that intermediate, or would you just go by the fact that...
Yeah, for the intermediate.
FFR, please.
Yeah, actually, before going with a balloon, I'll take FFR and be sure that it is positive. Otherwise, I'll leave it like this.
Frankly speaking, I didn't measure the FFR. Usually, I didn't measure the FFR in this case because even though FFR is lower than 0.80, I don't like touch the high diagonal range because we previously analyzed our registry data. The final catching balloon did not improve the patient outcomes. In addition, if we have to put another stent, that circumflex and high diagonal range is very close. So the further T-stent or cross technique may not be effective and safe. So, but for the live demonstration, I'd like to show you the.
So for the audience, I just want to say that
the high diagonal circumflex, they both supply the lateral wall, and with both being compromised, there would be, high chance of ischemia from one or the other. I agree that the circumflex probably doesn't have the money is in the high diagonal or the OM, whichever you'd like to call it, but I'd probably not worry about the circ. But certainly I would have had a bit of concern before we started. Now I think it's a bit too late because you don't want to mess up your left main into LAD in trying to open up a small diagonal. That's what my thought would be. If there was concern, I think we've passed that bridge now.
Well, not really, but on the other hand, I understand Professor Ahn's thought process around it. You've got what looks like around a 70% or less stenosis. Yes, I mean, it can still be tapped if you really want to, but you have to demonstrate ischemia on that, and then it can still have a tap onto that. So, but certainly just a kissing balloon would be disastrous because there's a long segment osteal proximal disease in that vessel. So I think he's doing the right thing to actually firstly assess for ischemia and perhaps leave it alone, hopefully.
So you're
Okay.
running the IV adenosine?
Yes, we prefer the IV adenosine. I already crossed the high diagonal branch.
Yeah.
Fortunately, not so difficult. Anyway, could you infuse that?
We don't.
I think this is a great demonstration, Professor. This is
resting
valuable.
PDP is 0.96. I believe
Right.
definitely negative FFR more than 0.80.
There we go. And that
That's
again
enough.
is a tremendous demonstration.
That is enough. I think you don't need even adenosine. I mean, with this, you'll never
I
go
agree,
for.
I agree, I agree.
Yeah.
Yes, based on the data, 2/3 of tight side branch FFR is more than 0.80. Even though less than
Look,
0.80.
actually, this case is very good to show how to keep things simple. I mean, bifurcation,
exactly.
You can do it with single stent, no ischemia, flow is very good in both branches. I think I think patient is not complaining about any chest pain. So I think this is a way to do it.
For me, this is simple plus FFR. I agree. This is a good demonstration.
FFR is a 0.84, 0.3. Okay, here you can see the table.
Okay.
One.
It's fine. Okay.
Yeah.
Fine.
Stop.
Fine.
So I think we've had a tremendous case, two tremendous cases. What are the learnings from these two tremendous cases? Of course, you saw, firstly, that these were difficult cases. These were complex cases. And yet they've been elegantly performed. The elegance in performing and what made it look so simple were three factors in my mind. Firstly, strategy. Strategizing came after imaging. And that, I think, was a very valuable part of whatever you see. Sizes were known, disease processes were well understood, calcification was identified, and a strategy was created following that strategy. Secondly, the strategy was the ones which operators were very comfortable with. It was a defined strategy in their mind. It doesn't have to be a mini crush. It doesn't have to be a cool-off. It is a strategy that you're most comfortable with while doing left mains, and apply that strategy again and again so that you master that strategy. That becomes very important for the two stent strategies up front, which you saw in the first case. They are masters of a mini crush. Someone else could have done it with a cool-off, but that's the mastering of the strategies. And finally, what you actually saw was keep it simple, keep it safe. And that's how you keep it effective for the patients. The second case, when you looked at it as a trifurcation, wasn't a heroic case where you suddenly said that I'm going to put 2 guide catheters and put 3 stents in a kissing manner so that I catch every ostia. And yet, what it ended up with this perfect result demonstrated by IVUS on the main vessel, and yet the 2 side branches were preserved with an FFR which was greater than 0.8, demonstrating no ischemia. Thereby, again emphasizing that if you strategize correctly and knew when to have it provisional and how to therefore manage a provisional technique, which is a valuable technique for safety as well as simplicity for the patient, it actually leads to great outcomes. And I'm sure both these patients are going to do very well. So we've learned a number of nuances of making things safe, effective, and unless, by the way, my final comment is that unless we match, we do the job perfectly, unless we actually have a great outcome on the table without complications, and we have imaging and optimize the result, only then would we be able to match the surgical results of left main surgery. And that, I think, is the most important things in our mind. With those words,
I'd like to show you final angio. Ready?
Yes, please. Great. Yves, do you have any final comments before we thank?
Oh, I will just add something. We know experience is very important. And I think teamwork and proctoring is important for young operators to make their experience, to learn how to perform this complex strategy. You have seen many exchange, many. So you have to go slowly to the left main. Very simple case, maybe 50 of them. After that, you can go to more complex. Experience is very important for the patient, also for you.
Thank you. Thank you very much.
My final, just small comment. I think we have seen great 2 cases. Then step by step, how should whether any technique you are using, you should go stepwise, and this giving you the possibility to end your job optimally every time.
Thank you very much, Professor Nakamura, Aniket Puri, Imad, yourself, and Professor Genwu. Thank you very much for being a part of this great session and your comments, as well as we thank Dr. S.J. Park, Dr. Janming An, and Dr. Dakwu Park, and the colleagues in the cath lab for a great live demonstration, which is going to be beneficial for all who attend this meeting. Thank you.
Thank you.
Thank you.